Jamila madam, good evening, a special good evening, madam. Good evening, our Honorable VC has come, and my own colleagues, everybody is here. We will start and others will continue to join. We will not waste our time. We all know that we are passing through a very critical situation, and we don't know how far we will be affected by COVID, and even the resource sufficient state countries are having troubles, because now the most important problem before us is the equity issues in vaccine delivery, etc. Because today I attended to a seminar in which it was shown that the lower middle income countries, their vaccination status, total vaccination status is actually 1/50th of the upper middle income countries. So that much is the gap. So 1/50th is the vaccine share, and the COVAX also couldn't keep their promises. They actually they have shown the vaccine share promised versus actual vaccine supplied, and it is only less than 1% in developing countries, and they have supplied about 50% in UK and USA and Canada. And other middle income countries, they have supplied nearly 10%, and in the poor countries where they should supply the maximum, they could only supply nearly 1%, even African countries. So that's a very, very serious equity issues we are getting into. So the knowledge updating is an important role of university, and we have did it through series of workshops. And in COVID, we have conducted international workshop, all sort of things we have conducted, and all of them were very beneficial to our faculty as well as students. And now we are touching pediatric COVID, and I thank everybody. First, our Honorable VC, who is the great inspiration behind all the academic activities of the school. And I also thank Madam Jamila Madam at the outset for finding time to be with us. Madam is a pediatrician. She was a very, very successfully practicing pediatrician. And then she was a medical superintendent for years. And then she happened to be in the chair of DHS and other administrative jobs. So Madam is here with us to guide us. And I once again welcome all my colleagues. My friends are there, Sandosh, Purushothaman, all my pediatric colleagues are there, and also other teachers like Indu, who are very much instrumental in the COVID guidance control in our government parlor. And I take this opportunity to thank all of them and to make this a fruitful discussion. I request our Honorable VC to make their remarks. Thank you.
Thank you, Professor Rajmohan, Professor of the School of Public Health under Kerala University of Health Sciences. Good evening to all respected colleagues in the university, the statutory officers, respected member of Planning Board, Government of Kerala, Dr. Jamila Balan, eminent faculty of today's webinar, dear participants and beloved students. Kerala University of Health Sciences is very happy to welcome you all to this very important and timely webinar on COVID among children, challenges and way forward for Kerala. The first case of COVID-19, as we all know, in India was reported in Thrissur, Kerala on 30th of January 2020. Even after 20 months, the pandemic is continuing, and Kerala is reporting the largest number of cases in the country as on today. But luckily, the mortality in Kerala is very low when compared to rest of the world. As on yesterday, India has vaccinated 100 crores of its population, a great achievement for all of us, and we can be proud about it. Kerala is able to give the first dose of vaccine to 94% of its population above 18 years. And we have been able to give 50% of our population above 18 2 doses. That again is a wonderful achievement. The strategy of vaccination of the adults is going on in the right direction. Because of this remarkable achievement in vaccination, the whole country is slowly opening up. Kerala is also following the national trend. On the 1st of November, we are planning to open our schools in the state. Very many concerns have been raised about the opening of the schools. Children under 18 are not vaccinated yet. Will they get infection when the schools are open? Of course, we all know that the incidence of COVID-19 among children is very low all over the world. Should we vaccinate our children? Are we confident about the safety of the currently available vaccines in children? Will there be any long-term bad effects? We insist on social distancing and wearing a mask to all. Will our children observe these? If not, what we can do? Will we be able to protect the elderly at home from the children who may be asymptomatic carriers? These are some of the real tough questions we are facing, and we must have scientific answers to all these. Our administration and political leadership are trying their level best to solve these concerns. But it is the duty of the scientific and academic committee to provide accurate scientific answers and solutions so that the state and national leadership can act upon. This is the very purpose of this webinar. Hope we will be able to provide answers to the challenges of COVID-19 among children and be able to suggest the way forward. I thank the esteemed faculty, Dr. Janaki Menon, Dr. Priya Srinivasan, Dr. K.K. Purushottaman, Dr. Sheila Sugunan, Dr. Geeta S., Dr. Sindhu T.D., and the moderator, Dr. Jamila P.K., for their great involvement. With these few words, I declare the webinar, COVID among Children, Challenges and Way Forward, if Kerala, inaugurate. Thank you very much.
Thank you, dear BC. We will have the sessions straight away, and some instructions. One is kindly mute those who are not talking, kindly mute. And second is that you can use the chat box for the question answering. Each session will be followed by 10 minutes discussion, and the senior people like Dr. Santosh Purushottaman, Dr. Indu P.S., Dr. kindly make the discussion moving on after each sessions, because we have selected 3 important areas. First, we will discuss about the clinical challenges, clinical management challenges. You know, the standard of care is not very well defined about children. Biologicals are not recommended. There are a lot of issues. Fortunately, we didn't have much problems, because in many cases, very few deaths, and even if the deaths happened, there are with the comorbidities. So that is a good thing about it. But still, clinical management is not a simple thing, and the symptomatic presentation also in children, in many situations, it is unique. So all these things will be discussed after the presentation, brief presentation of Dr. Priya. Then we will straight away go into the immunization, because vaccine is the answer, but for children, the supply management problems are very high. And as our Honorable VC has rightly remarked about the brand value and which brand to be preferred. So these are all, perhaps these are all easy for the developed countries, but it is all very difficult for us. And fortunately, we could make a vaccine of our own, and we could give it to 100 crores, and all those things we could achieve. But in the case of children, it is not that easy. So yesterday, there was a very important meeting about the high-level Apex Committee on vaccine decision-making in India. which is chaired by Dr. N.K. Arora. And I don't know what recommendation they have taken. It is not easy. It's very difficult. And the supply chain management of system of the vaccine, and it will produce serious equity issues. Because that is being discussed in many of the public health forums nowadays. And we will discuss, and we have a doyen in that field. Dr. Shija will be presenting, and after the brief presentation of Dr. Shija, we will have a very good discussion, and Santosh is here. Many of the knowledgeable persons are here. So we can have a 10 minutes discussion after that. Then we will have a discussion on the social issues. There are a lot of social issues, and in UK they have described the lockdown period as imprisonment for children. So we are here also. We have the school opening related problems, and Dr. Geeta, who is a very much socially committed pediatrician, is making presentation, and we will have a discussion for 10 minutes after that. Then we will have the overall panel discussion, and during the discussions of these 3 sessions, kindly use the chat box, and we will have a discussion, comments, etc. After viewing the problems in the chat box, and the seniors also can use it. For the 10 minutes, we will make you mute. Other times, the presenter only can unmute, and all others kindly mute. Then the last, we will have a panel discussion based on the questions raised on this, and we will have Jamila Madam to moderate it. Thank you all for your patient listening and cooperation. We shall start with I request Dr. Janaki Menon to have the session.
Thank you, sir. Thank you, sir.
Because everybody knows each other, but still I am introducing Dr. Janaki. Is the professor and additional professor and HOD of Thrissur Medical College Pediatrics, and Janaki is a very highly academic and proficient person. And thank you, Janaki, for joining us with this mission. And over to Janaki. You can introduce Priya. Thank you.
Thank you, sir, for inviting me to be a part of this interesting webinar. If I could just share my screen, I have a couple of slides I would like to share before we go on to Priya's exposition.
Actually, it is over to you, and you are the master of this session, so you can decide whatever way you want. Please.
Just a couple of words as introduction. In the early days of the pandemic, so we are now 2 years into the pandemic, which started in November 2019, we had data coming in from China, which indicated that children had mild disease. And we were all very relieved to hear that. And the presentation was generally of a mild upper respiratory infection and diarrhea. And then we saw that drugs like azithromycin, HCQ, ivermectin, antiretroviral therapy, favipiravir, remdesivir, etc., were all tried and then abandoned. So this was all based on evidence. 6 months into the pandemic, there were reports of Kawasaki-like illness in older children, which was described initially in the UK as PIMS-TS and later as MISC. And they started treatment with IVIG because it was a Kawasaki-like disease, and later found out that steroids were quite beneficial in this disease. Now, as we move along into the pandemic, here are the current gaps which I felt we would like to cover. And that is about post-COVID syndromes and conditions like obesity, because we are having an epidemic of obesity predisposing to thrombosis in children, immune-mediated phenomena other than MISC, milder presentations of MISC, diagnosis and management of the same, atypical presentations of MISC. And what about MISC in children with comorbidities? Are they more vulnerable to this disease? So since Rajmohan sir was keen on bringing up research questions, I thought these were the gaps that we would be interested in looking at. And yes, in spite of this high incidence of COVID in our country and in our state, we still have a dearth of evidence. And the real need of the hour is a comprehensive registry to generate evidence that would guide treatment protocols and healthcare policy in the future. So here is where we are not doing very well. All our data is number of cases, number of deaths, number of males, number of females, but we don't go into anything more than that. So we need more data and a comprehensive statewide registry would give us this data. Now, a word on pediatric services that have been hit by the COVID pandemic. Immunization has been hit, essential newborn care and follow-up has been hit. Newborn screening has been hit badly. Infant feeding practices have been really hit. Exclusive breastfeeding is suffering. And follow-up of children with chronic illness is very difficult. Nutritional programs like food from the Anganwadi, midday meal program and from school, and the weekly iron folic acid supplementation from school are naturally not happening. And as far as infrastructure and human resources of pediatric care are concerned, all over the world, pediatric spaces have been taken over for adult COVID care. Pediatric human resources have been deployed in adult care. Specialist services are not available for this very complex condition called MISC. And medical education, as we all know, has also been badly hit. UG students, I think, are an underutilized source of manpower, and they have been sitting at home for the last 1.5 years. So these are my introductory words. I'd like to quote the UN Secretary General, who said that COVID-19 is like an X-ray, which reveals fractures in the fragile skeleton of our societies, laying bare the risks that we have ignored for decades. And here is a chance that we have to find those fractures and to heal those fractures so that we can be a new and a much stronger community than we were before. So with these words, I think I would like to invite Dr. Priya Srinivasan, who is Associate Professor in Pediatrics from SAT Hospital, who has a lot of experience with COVID, managing COVID, to start her presentation on the challenges faced in the clinical management of COVID and MISC in pediatrics. Thank you.
Thank you, madam. Good evening to all. I see a lot of my great teachers here. First of all, is my slide visible?
Yes, well seen.
Okay. First of all, let me thank the Honorable VC Mohanan sir and Raj Mohan sir for giving me this wonderful opportunity to present this topic in front of my great teachers and colleagues. So the topic is COVID-19 among children, clinical management challenges, the Kerala scenario. Now I'll set the scene under this following headings, that is the COVID-19 data among children, that is the Kerala state, from the Trivandrum district and from major government medical colleges. And is this data worrisome? We'll see. And the Kerala state guidelines, which was put forward, that is the latest guidelines in August 2021. And the challenges we face in the pediatric COVID-19 management, and again, the challenges in the MISC management. Now, this is the Kerala state data given by the additional DHS Meenakshi madam. And here, what I would like to highlight is that in 2020, the number of cases were 1 lakh, that is in the whole of the state, whereas in 2021 till October 12, the cases have, it is 7.5 lakhs. So that is from 1 lakh to 7.5 lakhs. So definitely, there are cases that this is the data from 0 to 19 years, and you can see the data that is the less than 5 years, 5 to 9, 10 to 14, and 15 to 19. And the total number of cases, that is the total cases 0 to 19 years till date is 8.5 lakhs, which constitutes 17.8% of the total number of COVID positives of the state. And the deaths, you can see the number of deaths that is under 5, the total number of deaths till now is 23. And another important point is that from 15 to 19 years, the total number of deaths is 31. And the total number of deaths from 0 to 19 years is 71. And this is from my own district, that is Thiruvananthapuram district, and this is given from the DMO office, that is 0 to 9 years and 10 to 19 years, that is the data which is given. And 0 to 19 years, we can see that again, 75,000 cases in Trivandrum district alone, and it constitutes again 16.8% of the total cases, COVID positive cases, and the total number of deaths 0 to 9 years, it is 10 deaths, and 10 to 19 years, it is 5 deaths. So a total of 15 deaths among 4,049 total deaths. Now, this is the data from SAT hospital where I work. That is the admissions, the pediatric COVID admissions, the category A, 358 admissions, and this is a tertiary care center, 358 admissions, and category B, 534 cases, out of which 153, that is around 28.5 had comorbidities, had comorbidities. Category C, 133, out of which 40%, that is 59 cases had comorbidities. And missed C, that is 23 cases, that is they were COVID positive and hence were admitted in the COVID wards. And a total of 1,048 cases were admitted in SAT hospital till now. And the number of deaths were 10, and that is 0.09%, that is the case fatality rate. Now, this is from the major government medical colleges, that is GMC Kottayam, there were 350 cases with 7 deaths, and all 7 had comorbidities. That is the case fatality rate is 0.02%. From GMC Alleppey, it is 375 cases, and they have data from 15/10/2020. There were no deaths. And GMC Thrissur, there were 217 cases with 6 deaths, and all 6 had comorbidities, 0.02%. And GMC Kozhikode, 930 cases with 16 deaths, 15 had comorbidities, and the percentage is 0.01%. Now, this is the chart which we all know. That is, we have categorized the pediatric COVID into that is category A, category B, and C. And here, what is important is that the fever has been categorized. So any fever is category B, and category B means you have to admit. So any fever means we'll admit. So that is actually that is one challenge. And the next thing is that category C includes all the red flag signs. And that includes the seizures also. And seizures means that even includes the febrile seizures, which it's maybe the simple febrile seizures, which may last for 1 to 3 minutes. So that also comes as category C and will get an admission. And again, and now this categorization is for the administrative purpose, that is where to admit. So that is one thing, where to manage, to be exact. And the mild, moderate, and severe, this classification is mainly for management purposes. And these were the challenges we faced during the managing the cases. That is mild disease, like category A, 358 cases, and category B, 381 cases without comorbidities were managed in a tertiary care center. And that was mainly because of the panic among parents. That is because of fever. Now, most of the admissions were because of the fever or even a persistent fever, or because of some simple issue like a febrile seizure and diarrhea. And most of the time they were admitted for erratic saturation measures, because these parents, they will do the saturation, they will see the saturation at home, and a saturation drop means they will there will be a panic and they'll come to a referral center. And there is even a panic among doctors, and so they'll be referred to a tertiary care center. And what did we do? Actually, the management, what we gave is simple paracetamol for mild disease and all. We had to admit, and then we gave paracetamol, just the usual food. For diarrhea, we gave ORS and zinc, and nothing else. So actually, the resources we had to redistribute. We had to distribute the resources, they channelize the resources, the human resources, the time, the money, everything we had to channelize for these patients as well. So that was one big challenge we had to face, that is with the PPE kits and all. And actually, and all these patients, they had a long stay in the hospital as well, because once the child becomes negative, the caretaker becomes positive. And again, the caretaker is not well, they'll not go home. And once the child is symptomatically okay, fit for discharge, but there'll be grandparents at home. And so again, they'll not go. And because of some social reasons, like there'll not be anybody to take care. And sometimes they'll be so demanding as well, like demands care, and till complete recovery, they'll not go. So, and sometimes sometimes there'll be delay in these RT-PCR results as well. So because of all these reasons, so all these prolonged the stay in the hospital for this mild disease. And initially in 2020, we used to give them zinc, vitamin C, and vitamin D as management. And later we learned that it is of no benefit and no added benefit. And actually we stopped giving this year. And regarding the comorbidities, 210 patients or 20% of our patients had comorbidities. And the major comorbidity was malignancy, because we have the regional cancer center nearby. So 51 patients were admitted with malignancies, and seizures and neurologically abnormal children constituted 46. Then nephrotic syndrome, 28 cases, that is with relapse and even without relapse. Then chronic kidney disease, 8, CHD, 12, so gastro, hemato, and new onset diabetic ketoacidosis, 5 cases, co-infection with dengue, 3. So these were the different major comorbidities. And the febrile seizures, again, it is the simple febrile seizures, 21. Again, simple ADD, 11 cases, reactive airway disease, 8, pneumonia, intussusception, so surgical abdomen, intussusception, acute appendicitis. So these were the different patterns we saw. And for the comorbidities, actually what we did was we just managed the comorbidities just like we manage it every time. Like it was not different from that in a COVID positive patient. And the category C, we had 133 children, and that is 12.6% of our admissions, and 40% had comorbidities. And in without comorbidities, the majority had seizures, that is 54%. And in this category C, what we did was just a supportive care. And added to the supportive care, in selected patients, we had to give steroids and oxygen. So that is only for a selected few. And these are the guidelines. This is the August 2021 guidelines, which I am projecting. And in 2020, for category C cases, we used to give hydroxychloroquine and azithromycin. But now, again, we have learned that it is of no benefit. And now we have stopped using hydroxychloroquine as well as azithromycin. And in the category C patients, that is a severe category C, what again, it is the supportive measures, and we give oxygen via prongs, and then the next step is CPAP, then we give an IV CPAP, and then mechanical ventilation if needed, and steroids for selected patients. And most of the severe patients, we give steroids. And what extra did we give is that the remdesivir. We gave remdesivir for 12 patients actually, and for 2 newborns as well. But one of the newborns survived and 1 died. And in this 12 patients, 10 survived and 2 died. So is it beneficial? Actually, we do not know whether it is beneficial because the number is very less. And again, along with remdesivir, we were giving steroids, we were giving supportives, oxygen, antibiotics, antifungals, so many supportive drugs we were giving. So we do not know whether remdesivir worked or not. And WHO does not actually recommend remdesivir because there is no mortality benefit, though it reduces the duration of hospital stay. And actually, we do not have any experience with tocilizumab and convalescent plasma. And ivermectin and favipiravir, all these are not recommended in children, and so we didn't give that. And a monoclonal antibody, recently we gave the cocktail for 1 child, that is a 16-year-old boy with a chronic kidney disease, and actually that child, that boy died. And we had a few atypical presentations as well, especially the neurological manifestations. Young strokes, we saw 3 cases, and 2 had IC bleeds and a transverse myelitis 2. So these occurred when they were COVID positive or within 1 month, usually within 2 or 3 weeks of this COVID positivity. Optic neuritis, facial palsy, we saw acute ataxia. So all these, most of these children, we gave steroids. And recently we had one interesting case, that is one orbital abscess. That is, this child came with an orbital cellulitis actually, and it was actually a very painful experience to see that child. And we did radiological imaging, and the baby had a large orbital abscess. And the radiologist also said there was a doubtful mucormycosis as well. And then the ophthalm people were telling the vision will be lost. And again, and the ENT people, they did the IND because it was part of a chronic rhinosinusitis and there was an orbital abscess. So they drained, and the microbiologist later told that it is not mucormycosis and it is MRSA. So, but the vision was not affected and the child went home. And so we didn't get any case of this pulmonary aspergillosis, no mucormycosis, no GBS till date. And this was one very interesting case which Shankar sir, that is published as a paper. It's a case report that is a severe combined immunodeficiency. Now, this child presented to us in January 2021 as pneumonia, and which didn't subside. Actually, it was persisting and the child was very sick. And then the RT-PCR was also persistently positive. And then it turned out to be the CB-NAT, that is tuberculosis positive, and then we gave ATT as well. And this child was, from January, this child was admitted till April. And the baby got discharged with this RT-PCR. Again, it remained positive. So persistent viral shedding. So that is persistent RT-PCR, it remained positive. Until now, this child is RT-PCR positive. Repeated admissions are there. So, and mutation was done, and genetic evaluation was done by Shankar sir, and it was found out as severe combined immunodeficiency. And the child is awaiting definitive treatment. And the another entity which is important is the severe COVID-19 with hyperinflammation. Now here the patient will have severe respiratory symptoms along with shock, ARDS, and macrophage activation syndrome. Now this is mainly because the innate immunity is acting and there is a cytokine storm which usually occurs within 2 weeks of disease onset. And here you will get very high inflammatory markers like an elevated CRP, ferritin, LDH, D-dimer, and the interleukins. Now, and there will be ancillary findings like a decreased lymphocytes, platelets, and a serum albumin. Now, this usually occurs in patients who have complex medical diseases and on immunosuppressives. It is common in adults and it is rare in children. But among our 10 deaths, we saw features of hyperinflammation with respiratory symptoms in 3 children. And but one child was a case of familial HLH. That is, that child had a sibling with an HLH, and this child was also diagnosed to have HLH. Again, it was Shankar sir's patient. Genetic evaluation was done and it was found to have familial HLH. And the second patient was a suspected storage disorder under our follow-up. And again, that patient was suspected to have an HLH again. And the third patient was the medulloblastoma post-surgery, post-chemotherapy patient who developed severe respiratory symptoms and hyperinflammation. So these were the 3 COVID positive patients with hyperinflammation we saw. And so for the severe COVID-19 with hyperinflammation, with the respiratory symptoms and all, the treatment, what the ACR recommendation, now this is the ACR recommendations which came in April 2021. What they say is that we have to treat with the glucocorticoids, which is to be used as a first line immunomodulatory treatment. And the second line is anakinra. Actually, we do not have an experience with anakinra. Now we'll go on to the post-COVID scenario, that is the multi-system inflammatory syndrome in children. And we had a great experience, that is 140 cases with 1 death in SAT hospital. And actually it is a very challenging to manage this mess because we say there will be an epidemiological link to COVID-19 in the form of either a history of contact or there will be a history of COVID infection, RT-PCR positivity, antibody positivity, or an antigen positivity. But in 20%, you will not get any of these. And then again, it can be missed. Now, early identification of MISC is very important. And we have in Kerala a lot of differential diagnosis. In small children, the differential diagnosis include Kawasaki disease, bacterial sepsis, ADD shock, severe dengue. And in bigger children, we can have again severe dengue, toxic shock syndrome, leptospirosis, scrub typhus, and even surgical abdomen, like acute abdomen. So these are the differential diagnosis. And we should have a very good lab support because this is not a clinical diagnosis. Along with clinical features, we should have inflammatory markers. So that is mandatory. And again, cardiology support, as Janaki madam already told, it is very, very important. Like round the clock cardiology support is needed because at any point of time, we need to have an echo getting done. And early identification of disease progression is also important because at one point of time, the child may seem to be okay. And after a few hours, the baby may go in for a cardiac dysfunction or a shock. And again, the treatment is again a controversy globally, whether to give IVIG alone, whether to give steroids alone, or whether to give IVIG plus steroids. And the treatment, again, supportive care in ICU. So that is also a challenging thing. Now, this is the clinical criteria. Now, again, it is indeed a diagnosis of exclusion, and the clinical criteria, along with lab criteria, is how we diagnose MISC. And here you can see that that is along with fever, mucocutaneous symptoms, GI symptoms, shock, then cardiac involvement, coagulopathy, so 2-system involvement. All these may you should think about MISC. And again, the laboratory criteria is very important. And what is important is that you have lots of new inflammatory markers which have come as laboratory criteria. So you should know actually these new inflammatory markers, the normal value, the cutoff for diagnosing MESC. And again, even the unit is also important, because different labs may give you the values in different units. And again, the units also we should be familiar with. So we can write it in a piece of paper or a chart you can prepare, and you can keep it as a ready reckoner. Now, this is the Minnesota algorithm, which gives you the cutoff values of most of these inflammatory markers. What we usually do is that as first line, we send the CRP and the ESR. Now, CRP, any value more than 6 milligram per deciliter is considered, that is the cutoff, and ESR more than 40. And we need to do a CBC, sodium and serum albumin, that is ancillary investigations. So a lymphopenia and a neutrophilia. So a neutrophilia, that is absolute neutrophil count more than 7,700. ANC, or the absolute lymphocyte count less than 1,000. The sodium less than 135. Serum albumin less than 3.5. And again, the first line investigations include an ECG. Actually, echo should also be included as a first line investigation. And NT-proBNP is very useful than a TROP-T. Now, NT-proBNP, again, the cutoffs depend upon the age of the child. Like if it is an infant, the value is more than 1,000. And 1 to 3 years, the value is 675. And from 3 to 6 years, it is 325. And more than 6 years, it is 250. So the different values we should know. And again, D-dimer, you should send a PT-INR and a LFT-RFT, because any derangement in the LFT-RFT, you should admit the child. And second line markers, there are a lot of second line markers, but ferritin tells you whether there is a macrophage activation going on, and LDH tells you whether there is a cell death. And you can also do other investigations like the procalcitonin, fibrinogen, TROP-T, interleukin-6, all these, depending upon the financial status. And plus, we have to rule out so many alternate probable diagnoses. That is, for example, if you're suspecting scrub, lepto and all, you need to send all those investigations as well. Now, the treatment of MESC, it is what is globally followed is the ACR guidelines, which came in April 2021. Now, here in life-threatening MESC, that is shock and organ dysfunction, what they say is that you have to start IVIG 2 gram per kg over 12 hours plus steroids, that is IV methylprednisolone 2 milligram per kg per day. And if the fever is persisting, the symptoms are persisting beyond 36 hours, what you have to do is you give high dose methylprednisolone 30 milligram per kg per day for 5 days. And then you continue with oral prednisolone 2 milligram per kg per day for 3 weeks. So that is how you manage life-threatening situation. Now, what the problem here is that the finance, that is IVIG, there is a financial issue. So in our guideline, now this is the Kerala guideline. I told you the Kerala guideline which came in August. And now what we do is we start with IV methyl. Now in life-threatening situations, we start with IV methylprednisolone high dose, that is 10 to 30 milligram per kg per day for 5 days. And then we'll continue with oral prednisolone. And if the patient, the symptoms are persisting beyond 36 hours, there is fever means, then we give IVIG 2 gram per kg over 12 hours. That is what we usually do. Now, in non-life-threatening MESC, that is all hospitalized MESC, what ACR tells us that we should give IVIG 2 gram per kg over 12 hours. That is for all hospitalized MESC. But again, the finance is the issue. And what we usually do is that we give IV methylprednisolone 2 to 10 milligram per kg per day. So that is depending upon the situation. And 20% of MESC may not require admission. So in such situations, they should be monitored. They should be evaluated daily. So they should come to the hospital for follow-up daily. And sometimes you may have to repeat the inflammatory markers and all. And the enoxaparin, that is the low molecular weight heparin followed by warfarin, may have to be given in if the patient is having a thrombosis, and if the ejection fraction shows less than 35%, and if the coronary artery abnormal, that there is an Z score, and if the Z score value is more than 10. And how we find out the Z score is, it is very easy. You have a calculator and just put the weight, height, and the arterial dimensions. It will give you the Z score. Now, aspirin we give for all MESC cases, that is 3 to 5 milligram per kg per day for 4 to 6 weeks. If the platelet count is more than 80,000, and if the liver function tests are normal, and there are no active bleeds means we give aspirin. And so this is how we treat MESC. And this is the experience from different centers of Kerala, that is which got published. And this is one of the papers from our own center, that is SAT Hospital. And this was published in Indian Pediatrics, and it was done by Dr. Shija. And here what they did was 32 patients they observed. It is an observational study from September to November 2020, that is 3 months, 32 patients. And the primary outcome what they took was, that is they just looked into the outcome after giving methylprednisolone and IVIG, methylprednisolone or IVIG. And the primary outcome was persistence of fever beyond 36 hours. So that was taken as actually a failure. And the failure in methylprednisolone was 2 out of 26 patients, whereas in IVIG it was 2 out of 6 patients. So that is the crux of the study. And the another study which got published, that is actually 2 centers were involved, that is the AIIMS Kochi and the Baby Memorial Hospital, Calicut. And here what they found out was from 41 patients, again an observational study, March 2020 to April 2021. And they gave steroids plus IVIG for 35 patients, and steroids they gave for 3 patients. And the study says that there were 2 deaths only. And this is another, that is the global information, that is whether that is IVIG plus steroids versus IVIG alone versus steroids alone. So 2 papers from the New England Journal of Medicine, which came recently, that is June 2021. In the first paper, 58 US hospitals, 518 patients were involved, and their primary outcome was after giving these drugs, shock or cardiovascular dysfunction after day 2. And what they have found out is that with IVIG plus steroids, that group, the shock or this primary outcome, which was actually, it is a failure. So the failure was in 17%, whereas IVIG alone, the failure rate was 31%. So that is the first study. And the second study, which I have shown here, is again a multi-centric study, that is 32 countries were involved.
Excuse me, Priya, can you just cut short, because
yes,
we are
this is my last slide,
sir.
Last slide.
We have 2 more sessions.
Okay,
Please.
sir. This is
And
yes,
we'll
sir,
have
this
the
is my last
discussions
slide. Okay, sir. So 614 patients now. IVIG plus steroids 208 cases. IVIG alone 246 patients, and steroids alone 99. And again, their primary outcome was a failure, that is inotrope or mechanical ventilation need for more than 2 days. And actually, they found no difference in the outcome with all these drugs. So this is my last slide, and I would like to acknowledge the following doctors: Meenakshi Madam, additional DHS; Praveen, who gave the district data; Shija, who gave me valuable clinical inputs; Mini Madam, pediatric neurologist; now Janaki Madam from Thrissur; Vinitha Trivandrum; Sindhu Kozhikode; Nisha Krishnan from Kottayam; and Reshma Alappuzha, who gave all the data from all the different government medical colleges. And again, I would like to acknowledge all my postgraduates who gave me valuable inputs regarding the clinical management. Actually, it is done. Now, this is the picture which I have shown. They have managed actually 1,048 kids. Actually, most of these postgraduates also they got COVID, they became COVID positive during the process. Thank you very much.
Thank you, Dr. Priya Srinivasan, for an excellent presentation. She has an experience of treating 1,048 cases in SAT hospital. And what I feel is that there should be a statewide registry for these cases. I think KUHS can take the lead for developing a registry, because this is a new infection, and we may have to treat more and more cases in the future, because we don't know whether the 3rd wave is going to come. And as far as children are not vaccinated, we are going to get more and more cases. So category C cases definitely may increase in the future. So it should be mandatory that we have to have a registry of cases, because experience sharing, and also we can have our own state protocol for management of complications like MISC and all. Thank you. And the session is open for discussion. I think we have to cut short the time for discussion. We are running short.
Madam, quick comments by Dr. Purushothaman, Dr. Santosh Kumar. Quick comments, very quick comments. Santosh, because he has extensive experience of managing COVID for the last 1 year. Santosh, one sentence comment, Santosh. Quick comment, Santosh.
Yeah, the commonest query that has come to me is this hyperinflammation during COVID and hyperinflammation of MISC. And people confuse it. People confuse the dose of steroid in these two situations because steroid dose is different in these two situations. So that is one thing which possibly need a little bit of emphasis. And regarding MISC, in this discussion, there was a mention of OP management. I do not manage MISC as OP. Those are the two comments that I want. Thank you.
Thank you. I think Dr. Purushothaman may make the comments in the immunization session. So we will go to the next session because we are pressed of time. Thank you very much. Janagi, any more comments, concluding comments from Janagi?
No, sir. This is fine.
Thank you very much, Janagi. Your team has done a wonderful work. Thank you very much. We will go to the next session. Dr. Shrija, kindly be remembered about the time also because we have to finish in time. Dr. Purushothaman will lead the next session, and Dr. Purushothaman, over to you, Purushothaman.
Thank you, Honorable VC and Rajmohan sir for inviting us. I won't waste much time because it's the most debated topic about the vaccination in children. There are people arguing for and against. There are pros and cons for this thing. I think Shrija is the best person to talk about it. So we'll hear Shrija's discussion. And maybe, as Rajamohan sir said, let us have the discussion at the end of the session rather than in between. So I invite Shrija to present.
Thank you, sir. Honorable Vice Chancellor, Dr. Mohanan sir, Pro Vice Chancellor, Rajmohan sir, the Chief Organizer of today's event, Jamila madam, esteemed teachers and senior faculties and dear friends, good evening, everyone. And I thank the organizers for this opportunity. So going straight to my topic. So I would be really concentrating on the challenges in vaccination in children. So we all know that as of today, we have more than 24 crore people who are being infected with the COVID virus, and around close to 50 lakhs have already lost their life to the disease. And more than 6.8 billion doses of vaccines have been given, with 37% fully vaccinated as of today. But unfortunately, the administration of vaccination has not been uniform. In Congo, it is just less than 0.1%. In fact, nobody is there who has received 2 doses of the vaccine. Whereas in UAE, 87% is fully vaccinated, with 97% receiving at least 1 dose. India is in between. We have crossed 100 crore vaccines, but unfortunately, it accounts for only 22% of fully vaccinated population in India, but also 50% of our population has received at least 1 dose. So with that, when it comes to vaccination in children, the 3 important points that we want to stress upon is definitely efficacy, need, and safety. If we are able to answer these 3 questions for any vaccine or vaccination strategy, we would be getting a solution. So first of all, coming to the vaccine efficacy, especially with the advent of new your Delta variant, which has been found to be highly infectious, but thankfully we have seen that data shows that whether it is the mRNA vaccines or the vector vaccine like Covishield, both are showing good efficacy against hospitalization even after 20 weeks. So thankfully, the newer strains have not been able to dent the efficacy of vaccine as far as hospitalization is considered. But what about efficacy of vaccine as weeks post-vaccination happens? Here you can see that death comes down, the efficacy comes down, but still it is around 80%. But symptomatic disease, it is only 47%. That means for a vector vaccine, post 20 weeks, the chance of the vaccine preventing a symptomatic disease in you or an asymptomatic disease in you is less than 50%. And The reason why the vaccines don't prevent infections or asymptomatic or symptomatic mild infections is because the vaccines that you are using are definitely not the ones which is going to give you a sterilizing immunity. They are vaccines which are being given parenteral, and so your antibody titers may be high in your blood, but the IgA secretion is limited, so you don't have much of protection in your mucosa. So that means that the wild virus, the COVID virus, can definitely multiply in your mucosa and infection can happen. Now, regarding the breakthrough infections, it has been shown that this is the data from the CDC, and they have shown that 88% of the breakthrough infections are either asymptomatic or mild. So that is a very good news. And only 2% death in those who are vaccinated. And among the death in the breakthrough cases, it has been found that the median age was 82 years. And among them, 20%, nearly 20% occurred due to causes other than COVID. That means they had some comorbidity, they had a COVID positivity, but the cause of death was not exactly COVID. And unfortunately, for those patients who were sequenced, majority was the SARS-CoV-2 variant of concern. So as far as the new variants are concerned, we are worried that it is causing breakthrough infection, and the small amount where it is causing death, it is the one that is majority responsible. Now, this is another recent report again from CDC. Here, what you see exactly here is that Massachusetts is this place where more than 70% is vaccinated, fully vaccinated. That is 2 doses of vaccine has given. And here you can see that in the preceding weeks, it was not reporting any cases. So somewhere it was where the cases was in digits or nil, but then suddenly their cases have really gone up. And this was because of they had multiple events and large public gatherings. And just because your population was immunized, so naturally it was the immunized population that mainly contributed to the disease. So again, emphasizing that when you are vaccinated, you still can get infected. The risk of mild infections and asymptomatic infections still remains high. So just because we don't have infections for 1 or 2 weeks, we should not think that we will not get infected in the near future with a new variant. So that is an important thing. And here you can see that the median age was 42 years, because probably that is the age people who are going out for the gatherings. And 90% was due to Delta variant. Another important thing that we need to know that the RT-PCR CT values in vaccinated patients were similar to those unvaccinated. That means when you are having the infection, the viral load seems to be similar. So vaccination is not decreasing the viral load in the mucosa. On the other hand, when it comes to data from children, it has been found that the viral load in children is similar to the viral load in adults. And in adults, usually it has been found, some studies have found that increasing in viral load is related with increased severity of symptoms. But whatever study we have from children, it has shown that the viral load is same in symptomatic and asymptomatic children. So that is also a point of concern, that is children seem to be as infectious as adults. But when you look at the how the different vaccines fare, you would realize that when you look at the mRNA vaccines, they have very high peak compared to your vector vaccines, where the peak is considerably low. But as you can see here, from a very high peak, after 8 months, it has rapidly came down. So there is a rapid decay in live virus neutralizing antibody. Thankfully, in the vector vaccine, even though the initial titers were low, the study showed that the decay was not prominent. In fact, so you are having a slightly higher titer there, in fact. And when it comes to CD4 T cell response, you can see that as far as RNA vaccines are considered, there is not much change in the CD4 T cell response. And also, there is not much change in the CD8 T cell response. And even your vector vaccines also face similarly, even though for them, the CD4 T cell response was less. What I really want to tell here, or what I'm trying to convey here, is that vaccine kinetics differ. So depending on the type of vaccine that you're using, you would know that whether the vaccine, how much antibody you're getting, how fast it is decaying, what kind of protection it is giving. Is it giving you a humoral protection, or is it giving a cell-mediated immunity? So there are a lot many questions that we need to know. and data from one vaccine study cannot be extrapolated to another vaccine. So now coming to, and that is the exact reason the CDC has now come up with booster shots. So now everyone above 65 years is offered a booster there, and anyone above 18 years with a high risk setting is offered a booster, and high risk settings would include anyone from the first responder, that is your healthcare workers, your police, to a grocery store workers. That's almost literally everyone is being offered a booster. And now the booster is not only Pfizer. CDC says that the US citizen can take any of the vaccines, that is Janssen, Pfizer, or Moderna, and they can also do a mix and match. That is irrespective of what vaccine they took initially, they have the liberty to take the booster with any vaccine of their choice. So when it comes to vaccine efficacy in adults, we understood that vaccine does not produce a sterilizing immunity. Breakthrough infections with newer strains are very high, but there is a definite waning vaccine effectiveness beyond 5 to 8 months. A lot more research is needed to the vaccine kinetics, as they seem to be different. Chance of hospitalization and death is significantly less in vaccinated. But what is the need of COVID vaccine in children? So we know that COVID vaccines, COVID disease is definitely on the rise. And similarly, the death, even though the case fatality rate has come down, but still the deaths are happening. So that is a point of concern for us. And post UK school opening, they found that there was an increase in COVID cases in children. But here again, you can see that the increase is mainly in the 5 to 12-year age group and not in less than 5-year age group. And this is another study from Israel, which again shows that the incidence rate ratio and the test positivity ratio post-school opening did increase. And here again, the vulnerable population was 10 to 19 years and not the 0 to 9 years. And that is why some experts feel that elementary school opening is okay. It is the other school opening that may lead on to an increase in cases. But what we need to know that schools are opening, children getting infection is definitely, the chance of them getting infected is definitely increasing. But they, as a source of infection, as a primary source of infection for the family members, that is what we were concerned about. And here that you can see that only 9% of children less than 18 years were the primary source, irrespective of whether the incidence was increasing in children or not. But even when the school was opened and even when the incidence in children increased, that did not lead on to the child acting as a primary source of infection to the household members. Less than 2% in children less than 10 years were responsible for a primary source of infection in the house. So COVID-19 mortality is more in males. There is an exponential increase in COVID-19 related mortality with age. Increase in age of 10 years increases the mortality by a factor of around 4. And when you look at the age distribution, we know that less than 45 years, it accounts for only 4% of the COVID mortality. When you go a little more deeper into it, you would realize that children less than 10 years account for just 0.16% of the total COVID deaths. And regarding the age group and mortality, here again, you can see that the mortality was slightly higher in those above 10 years of age. In fact, the preliminary analysis of the Kerala data, that is close to 70 cases of death in children, also showed a bimodal pattern. In fact, in Kerala, we had some children increased incidence in those less than 1 year and also increased incidence beyond 10 years. But here we have to understand, while we're talking about 70 odd cases in children, 27,000 adults have died due to COVID in Kerala meantime. So mortality as per is very low. But unfortunately, when you combine the ethnic group and mortality, it has been shown that usually the Asian contribute to only 16% of all-cause mortality. But when it comes to COVID, it contributes 36% of all-cause mortality in England. So what this is trying to say is that COVID seems to be causing a higher infection and higher mortality in the Asian population compared to other deaths. And as already highlighted by Dr. Priya beautifully, that most of the cases of children who are admitted are mild disease. 10% happens due to MISC, and plus to 8 to 12% is due to moderate or severe COVID. And when you analyze the death in COVID-19, you would realize that in England, death due to COVID in children, there were 5 deaths every 30 days compared to 250 deaths every 30 days, even during the COVID pandemic. So that is very important for us to understand that even during the pandemic, the cause of death, COVID as a cause of death in children is extremely rare. And 76% of COVID deaths in children had comorbidities. That is the study from England. But as far as Kerala is considered, 90% of our children who died had comorbidities. The commonest comorbidity was neurological comorbidity, that is patients with cerebral palsy, life-limiting neurological comorbidities. Genetic disorders where CNS involvement was there. That was the commonest cause. There was a few percentage of malignancy also there. And preterms and other complications lesser than 1 year of age also contributed to it. In England, they said they didn't find any case of trisomy, but we did have 3 cases of trisomy as far as Kerala is considered. We also had 2 cases of diabetic death numbers. So as far as mortality is considered, we understood that mortality in children is very less, and mainly it is in children with comorbidities. Now, what about morbidity? What about long COVID in children? Yes, it is a reality. Children can have headache, fatigue, disturbed sleep, and problems concentrating. The incidence reported has ranged from 2% to 14%, as against 50% in adults. So as far as need is considered, COVID mortality as a need is very less because mortality is extremely rare. CFR is 0.005 to 0.008. School reopening has increased cases in children, but no exponential increase in adults. Children as a primary source of infection in household is only 2 to 9%, but 10 to 11% of children can have long COVID. Increase in infection and admission with COVID post-school opening is being reported, and the breakthrough infection reported in India is around 10%. Now, finally, coming to the last question, how safe is COVID vaccine for children? The vaccines and the rare side effects, mRNA vaccines have reported pericarditis and myocarditis. Vector vaccines have reported thrombosis and GBS, and killed vaccines, Sinovac and Sinopharm has reported ADEM and serious neurological nausea. Unfortunately, we don't have data from Covaxin. So regarding post-vaccination myocarditis, we know that it is mainly in males, mainly in those less than 30 years, and majority happening after the second dose. It has been reported exclusively following mRNA vaccine, and the onset of the median duration onset of symptom is 3 days, and the duration of admission is 2 days. So that is very, very good. That means the myocarditis that has been reported following mRNA vaccines are milder in nature, but definitely there are cases. From US, there are 700 odd cases now, and some of them definitely are requiring ICU care also. So in a large study involving 2.5 million healthcare officials, organizations from Israel, they had showed an incidence of 2.13 cases per 1 lakh vaccinated. The recent incidence from CDC is 3.8 per 1 million after first dose, which dramatically increases to 57 per 1 million for the second dose. And the highest incidence is 16 to 29 years. And probably the incidence may be higher in the smaller age group as the vaccines open up for them. So, but fortunately, most of the cases of myocarditis, as I already mentioned, was milder in nature, and follow-up is showing a complete recovery. But it is important for us to know that this was a study done in 1,500 odd US competitive collegiate athletes, and where they found that the incidence is 2.3%. That means you're having 2 persons for every 100 infected with COVID in a young adult developing clinical or subclinical myocarditis, against what we already said. Even when you say 60 cases, it is against 1 million people. So definitely the incidence following COVID myocarditis is more than incidence following vaccination. And Pfizer has now decreased the dose of the vaccine. Adults, they are recommending 30 microgram, and for children 5 to 11 years, it is 10 microgram, and still the antibody titer is higher compared to adults. And for those less than 5 years, Pfizer is now recommending 3 microgram. So we do not know whether the robust antibody titer in the young adult is a reason why they are having a higher incidence of myocarditis. Probably they're looking at a lower dose to see if the incidence of myocarditis comes down. It is important for us to remember that these side effects came to fore only after the vaccine was introduced in the younger age group. It was not detected while the safety studies were undergoing. That is, the phase 3 trials did not alert us to this possibility. And specific age groups, they have decreased the doses to see whether the incidence can be brought down further. Now coming to the COVID vaccines that we currently have. So Plasmid Dna Vaccine, that is the ZyCoV-D, is the world's first human plasmid DNA vaccine. It is approved for in India for those about 12 years. It is a very stable vaccine. It can be stored at 25 degrees centigrade, mind you, for 3 months. And it's a needle-free intradermal injection, 3 doses at 1 month interval. So that seems to be a very big breakthrough as far as India is considered, with a 67% efficacy. But on the flip side, the phase 1 and phase 2 studies have already been published, but the phase 3 study is not yet published. There are no studies in adults even that is published, and we have a vaccine that is licensed for children. And there is an efficacy of 67% is claimed. So we do not know the varying vaccine kinetics in adults. We do not know the larger safety profile in children as well as in adults. And we also need to remember that, in fact, there is no DNA vaccine in adult. This is considered as a first DNA vaccine, but that does not mean that it was DNA vaccine platform was something that we did not explore before. This was a vaccine platform that was explored before, but that was made and failed because it was found difficult for DNA to enter a human nucleus and then synthesize the RNA and finally come out and synthesize the protein. Whereas DNA vaccines are currently used in animal vaccination programs. So we have to wait for a little time to really look at the safety and efficacy real time. Coming to Covaxin, it's a killed vaccine, 2 doses 1 month apart. It's the same schedule that has been recommended for children also. And now the experts have recommended for children about 2 years of age. Vaccine is currently being given to multiple countries, but mainly in Southeast Asia and some African countries. Phase 3 trial had involved more than 24,000 patients, and it showed a 78% efficacy. And in fact, the phase 3 trial, one study has already been published, but it mainly shows a lot-to-lot immunogenicity of the inactivated SARS-CoV-2 vaccine. So here again, the earlier limitations are there. The number of children in the study was just 525. So we really don't know how children fared compared to adults. It is unfortunately not yet approved by WHO for use in adults. And the lower antibody titer has been shown, especially in pregnant ladies, when you compare Covaxin and Covishield, whether a lower antibody titer can lead to an antibody-mediated enhancement, or in simple terms, what you call it as the first antigenic sin. Is that possible? Making them susceptible to more severe infection in the future is not yet completely known. So there is definitely safety data lacunae as far as our 2 vaccines are considered. So it's important to remember children are not small adults. Their immune system responds differently to vaccine compared to adults. Longer life period ahead also may be at higher risk of the first antigenic sin. Studies of Indian vaccine phase 3 is not completely published, and Indian vaccines authorized for use in children is not yet approved by WHO. So to conclude, children need to be vaccinated to stop pandemic. That is what we said. But fact is, vaccines do not provide sterilizing immunity. So even after you have vaccinated, you may still contribute to the spread of infection. Incidence of disease in vaccinated is far less, yes, but it is even much lesser in children compared to adults. Children can spread disease to adults, but newer studies are showing that children are often not the primary source of disease in children, in adults. So it is important that what we need a vaccine in children, that is definitely, but there is no role right now for an emergency use authorization. We want the routine authorization, and we want a transparent safety data. We want to protect our child, because symptomatic infections, even though less, are definitely increasing. Even though the case fatality rate is low, but there is still mortality, and long COVID 2 to 11% is there. So we need to have a vaccine, but safety data and immunogenicity data peculiar to children are definitely needed. So just like the child seems to be asking a doctor many unanswered questions, we also do have certain unanswered questions as far as COVID vaccines are concerned. Thank you.
Thank you, Shrija. I think we'll have the discussion at the end. Dr. Rajmohan sir?
Some quick comments. Purushothaman, you are the best person to give comment, and also Jamila madam, to make a few comments, 1 or 2 minutes.
Yeah, in short, as expected, the final comments, let us wait and let the vaccines prove safety beyond doubt. There is no hurry. That's in short. There are people who are asking for the vaccine. And just one comment from Gagandeep Kam madam last week, that if she opts for a vaccine, she'll go for killed vaccine, not for the psycho-D. That was her comment. But I have a different opinion. I have a different opinion about that, because we don't know how this MISC like situation happens. As long as the pathogenesis mechanism is not known, we don't. There is every chance that a killed vaccine can lead on to a sequence like that, because 525 samples is too inadequate to say that such an incidence is not possible, because the incidence of MISC among the infected is too low. So there can be a possibility of MISC with the killed vaccine. So rotavirus vaccine cannot be safe. And one more thing, rotavirus vaccine dose is same as the adult vaccine. There is no trial with a lower dose as the Pfizer vaccines and the mRNA vaccines. So about the opinion from the Jacob Jones sir also, he says children should be vaccinated. That's again cannot be taken as such, because again it's contradicting. He says that 95% seroprevalence will be there. In that situation, what is the need? It's a pediatric population, 42% seroprevalence. Maybe by this time above 50, and maybe after a few more weeks it will be somewhere around 85%. What's the need for the vaccinating children in a hurry, unless it is proved beyond safety beyond doubt? So only thing, if at all vaccination is needed, restrict to the high risk category, among the highest risk category of the kids, and we'll wait for the vaccine. Maybe better vaccine will come. Even the new study with the mRNA with the lower doses and that sort of studies. And if at all we are going for a vaccine, I'll wait. I'll go for the conjugated technology, the Novavax equivalent from the Serum Institute, the Covovax. That may be a better choice. Even that we'll wait, and after next year only, I think we can decide. That's all.
Madam Jamila, madam, one comment.
Regarding vaccination, even vaccination of the adult is a big challenge to us in the state. Initially, we had problem with the availability of vaccine. We have covered 94% of the target population with the first dose, and only 47% of the target population with the second dose. So in our list, regarding Covaxin, we have more than 3.69 lakh people with the overdue list, in the overdue list. And with Covishield, we have 8.22 lakh persons in overdue list. That means for the adults, that is above 18 years, we have an overdue of 11.91 lakh people in our state. And next is, we have to vaccinate more than 1,26 lakh and 77,000 people in Kerala. So this is the challenge before us for the adult vaccination. Now we have received enough vaccines, and the state capacity to vaccinate per day is 1.5 lakh now. Now it's vaccinating only 1.5 lakh per day. The capacity of the state to vaccinate is 3 lakh without compromising other activities, because now initially Janaki madam had told us that our national programs, we are not conducting any national program. We are far away from the national program. Now we have started our national programs. So without compromising our national programs, we can vaccinate only 3 lakh people today, per day. So we don't know anything about the vaccination in children. And as a state, we cannot take any decision. Government of India has to take the decision, and we can act accordingly. And we don't know which vaccine, how many doses, how many children, which age group are selected and all. So we'll wait for that. And that is what I want to tell you regarding the vaccines.
Thank you, madam. Thank you very much. There are a few questions. I think we will, Mohandas has asked a question. More important is to vaccinate all adults with 2 doses. So anyway, we will discuss all those things in the end during the panel discussion. All the questions in the chat box we will discuss. I don't know whether any glaring comments by any senior persons. Otherwise, we will go to the next session. We will go to the next session. Dr. Geeta.
Good evening, sir.
You can lead the session. Over to you. Dr. Geeta is additional professor pediatrics, and she from the very beginning of her career and in pediatrics, as well as during her career as a medical teacher, she is interested in immunization, and she is one of the few persons who have attended national immunization trainings. And she is interested in immunization. But along with that, she is also very much interested in social pediatrics. So she has attended a lot of national programs, and especially her interest in tuberculosis. Now she is the right person to coordinate this session on social implications. And over to Geeta, and Geeta will introduce the next person. Thank you very much.
Thank you very much, sir, for the kind words. Respected Chairperson Jamila Madam, Honorable VC, Rajmohan sir, and all the distinguished faculties from the other medical institutions, and my dear friends. It's really an honor to be here listening to the previous speakers, Dr. Priya and Dr. Sheija. They have given a wonderful presentation regarding the COVID presentation, and also the need of vaccines, and whether, actually Sheija has actually told us whether the vaccine, some disturbance is there. I think my topic is regarding the reopening of schools. We are actually into that reopening of schools, that is from November 1st. And Sheija has already told that what has happened to the areas, especially in the West, where schools have opened. So how we are going to go ahead. Time only will tell us how it's going to be there. Hopefully, all things will go fine. I'll go into my presentation. കാണാലോ അല്ലേ? കാണാമോ?
കാണാം madam.
Yes, please go ahead.
Thank you. This topic was given by Rajmohan sir. Sir is a mentor for so many students, and I think I am one of his students, and it was a pleasure to interact with sir. Sir has actually seen our slides, and he has commented on most of the things. I've done this job with Dr. Sindhu from Kozhikode, and please, Sindhu will also be commenting at the end. So we all know, Shrija has told the burden of the cases. It has gone into millions world over, the cases among adults. And although the number of children who are affected is less, we have seen a significant mortality. See, even if one child is, we have seen low mortality, that is maybe one child in SAT or 2 or 3 here and there. But even that is a huge loss when you really consider that family, because this is a disease which has just come on all of us like that. We have seen how the Western, the developed world, like USA, Italy, UK, all were struggling. See, we never went into that situation, never in Kerala. And when you think that why these schools were actually closed on a sudden, we all know how this lockdown was there. It just stopped. It just stopped like that. Suddenly the decision to put the schools to closure was called. At that time, we never thought when we could, everybody was thinking maybe 1 month, 2 months, and then we waited, see, 1.5 to 2 years. And we never had a plan to reopen because nobody knew how it was going to far. And then, suddenly people were aware, see what has been the result of the school closure, not only in third world countries, but even in the West. If you see the literature, how much this school closure had affected them. And then slowly people were thinking of opening the schools. And so that is why the literature is on school reopening is more from the West. And definitely the vaccines which were developed so fast, that actually contributed to the control of the disease, and also like the the prospect of a school opening also. But regarding school opening, along with vaccines, I think the non-pharmacological interventions will be more important, and how that is going to do will actually tell us how this COVID is going to spread or just get controlled in the community after the school reopens. And we have seen, Shija has also mentioned that literature now says that in the countries where the schools has been reopened in phases, especially USA and UK, it's not that dangerous. And in Kerala, we all know the government has brought down guidelines, and actually we should understand that it's so much planned. So much amount of planning has gone in the national and the state level to open the schools. And you read the newspaper, you can see today also in Manjeri, ഒരു കുട്ടിയുടെ അച്ഛനും അമ്മയും കൂടെ പോയിട്ടാണ് ആ കുട്ടിയുടെ സ്കൂള് നീറ്റ് ആക്കിയെന്ന്. അവര് പിന്നെ മേശൻ ഡെസ്കും എല്ലാം നീറ്റ് ആക്കി, അവിടെ സാനിറ്റൈസ് ചെയ്തു, പെയിന്റ് അടിച്ചു. ഒരു അമ്മയും കൂടെ പോയി നിന്നിട്ട് പെയിന്റ് അടിക്കുന്നു. See, you should understand the community participation which has gone into control of this disease, even at a grassroots level. So I think probably it will all be positive only. So if you look into the positives and negatives of infections in a younger age, definitely we all know that burden was less. I'm not going to highlight on that. But very important is regarding the immune imprinting. That is, we have seen with dengue also, how the disease occurs, primary disease occurs, and then what can occur. Sometimes nothing will occur, but sometimes secondary infection, it is going to be catastrophic. So we do not know regarding this being a new disease, how it is going to affect our children, because the children have got a long life to live. That is very important. That is true also for a vaccine also. So that is why vaccines, if it is to be introduced, it should be in a very careful manner. And what are the negatives? And the negatives, we should think that children, we all know, mostly they are asymptomatic, and mostly children in our place, sometimes they don't get tested also. We all know very small babies and all. Our community may not take them for testing also, but we definitely know they are infected, and then, you know, it just disease goes away. And the infectiousness is not known, and the detection is difficult by that. And also the symptomatic children is less, is there, but the number is less. But the evidence from the school reopening in the West have shown that the transmission in schools is less. And by saying about the transmission, it is less even in the smaller age group children, I mean less than 5 years. Whereas in a secondary school children, higher than that, it may be, it is slightly less. Because the viral load is same in adults and in children, children can sometimes, there are evidence reports of being super spreaders also. So that is also very, we should consider when the school is being reopened. And serologic surveys also are comparable. Regarding the school closure, what was the experience from West? Initially, they had found that the school which was closed initially had reduced the spread of a disease in the community. And mostly in houses, so difficult to assess the gravity of school-based transmission. The school opening was then planned because by the time regarding the pandemic reports came, the children, the number of cases were less, the severity was less, mortality is less. And but what has happened, the psychosocial problems and the health issues, Dr. Janagi has already told that obesity is a challenge, but in areas where they are underprivileged, the reverse is also there. Because even in the Western countries, you see the literature from the Europe or from, it's mainly from the European countries, which have actually shown that disruption in learning. See, we have seen anecdotal reports, I'll say only, of children who do not have a phone or connectivity in our place, whereas UNESCO has reported great difficulties in places like a European country where there is food assistance. Children go to school for food assistance, and child abuse, homelessness, all these things, around 10% as reported from many studies. And mental health issues were unrecognized during the studies, especially the child. They are saying that the child protection reports, it is actually very important regarding the child safety. So the child protection reports during this phase has come down. So that doesn't mean that the violence or the abuse against children has gone down. It is only gone underreported. And also we all also have seen how they were also afraid to come to hospital. Now I am in Koni. I can very well say that our hospital was for a few for a few months, it was a COVID hospital. So actually we see in medicine and all, we see 120 patients per day, but in pediatrics, they are actually afraid to take the children. We have hardly say 15 to 20 only. So that is why the lack of access to medical service, especially for those with comorbidities, that was also a great thing, disabling for the community. For India, there are special issues, if you think, especially in some of the other states, child protection, child abuse, child marriage, child labor. These are very great issues. And NIMHANS have got some reports regarding regarding the child protection. They have actually come up with a lot of platforms online to support the mental health of children also. And mental health issues, that it is real. So I have given more points in that, because that is one key issue which will come out only when the school reopens and the children are able to communicate with the friends and also with the teachers, because they don't have an access to friends. We all know how if there are two children are there in a room, how it will be like that. No outdoor play, socialization, they are angry, frustration. It need not go into the higher level of illnesses. Even mild problems, they are also so much disabling for the child's development. Then definitely overuse of phones and the impact on the brain functioning is really a problem, because when they're going physically to the school, naturally the mobile phones will be decreased, the time will be decreased, and that's going to deal to a lot of issues as the school reopens, especially in families. It may never get reported probably. And there is a concept called distress spreads emotional contagion, because you're hearing all the bad news and all, and that actually goes and circulates. That is true not only in child, more in a child, and also in adults also. And very important when you consider the children who have lost one or more parents. They have got a great amount of stress disorder. Now probably they are at some of their relatives' home and they are being taken care of. Once they go to the school, and then they're going to face that enormous loss of their parents. And then definitely the financial insecurity, addictions, behavioral problems, especially of the teenagers. We also are we are actually aping the West, and I think we'll overcome that Western countries in terms of addictions and behavioral problems in near future. And COVID, I think, has actually put a rocket pole ee issues ne highlight cheyidu ennaanu enikku thonunnathu. I think regarding the strategies to be opened, regarding school opening, what we have to understand is we should have a safe opening. See, after opening, we should not have an instance where we'll have to close down. So that is very important, very, very important. And then remote learning, how it has influenced these children. And now also we think that hybrid mode may go on at least for a few weeks initially, and then restructuring of the curriculum regarding the academics. That is also very, very important. So what is to be done is like you have to think of the preventive strategies which we should do when the schools are being reopening, and then manage the potential cases and outbreaks. It's easy because it's very easy because in our state we have got a very dedicated and a very good healthcare system, local health system. Even everything is our digital penetration is also very good. So that's probably going to be very easy. And then we have to reduce the transmission of COVID-19 at the household level. We all know children can spread the disease. So it's very important that all the families where there are adults, they should get vaccinated by 2 doses, very good, or at least with 1 dose. And it's very important to protect the vulnerable groups. And also it's very important that after reopening, we should be able to continue like that only, and with uninterrupted learning strategies, because that is also going to be very, very difficult for the children. So regarding the schools which are closed, the reports have actually mostly they are conflicting, equivocal. That is, only very few SARS-CoV outbreaks have occurred in schools after reopening, especially in UK. This reference which I have used is from UK. The secondary cases which have occurred actually is more in the teaching and the administrative staff. So you'll see the guidelines of Kerala state that actually shows that we have to vaccinate all the teaching and the other non-teaching staff who are in contact with the children in the school, the drivers who take, the peons in the office, all these people. And based on this study by Ismail from UK, within school transmission had occurred in around 31% in children. It was higher in the secondary schools, that is 7/18. Although the secondary schools had a lower attendance rate, the incidents or the cases which occurred in the school was higher in the secondary schools when compared with the primary schools. Based on lots of modeling studies, they have actually found out that school closures avoided only around 2 to 4% of deaths in children. So that is why a planned phase of organizing or planning for a school reopening was done. This was in Sweden, was a country where it did not close schools initially. The epidemic was very severe in the adults. They had kept their schools open, but they did not report increased number of hospitalized children. That means the very severe infections were less. But definitely when compared with the other neighboring country, Finland, Sweden had infection rate in children considerably higher. So that was a Swedish model which was there in a UK. The number of cases was lower compared before school closures and indicated that the containment measures in the school, that is what is very important, the NPIs, that is a non-pharmacological interventions in schools are the effective, and that is very important that we have to implement. That is why in our schools, in our reopening plan, these are given a higher importance. When you compare data from West, that is UK, and how we are going to fare, when you think in the West, there was a low transmissibility. There was we can definitely think of when you think of our schools, effective school hygiene, you can imagine, which resulted in lower rates of infection in the West. How much that hygiene we'll be able to do. Our schools mostly may be able to do, but we should think of the other areas also. And asymptomatic cases may be missed in the West. Here also there is a chance of asymptomatic cases. In the West, when you think in a school, maybe 20 children will be there, but that is not the condition in our schools. Anyway, between 40 to 70 are there in one class. So that even if it's an asymptomatic number will be huge when you consider a country like ours. And the high probability of secondary students to introduce infection was the impression that we got. So how we are going to do, we have to do it in a very efficient manner. And by this time, already the talks are into vaccination. But when you consider vaccinations, as Srija said, they should be really safe and they should be efficient also. And definitely, as Madam said, that supply and the equity issues will also be there. When you consider school reopening, I feel the non-pharmacological interventions for safety and efficiency is there. But when you consider children, adults also, now we see people who are walking on the roads, how they have wearing their mask and all. When initially people were actually adherent to that. So how far we'll be able to look into the adherence of these, that is also an important one. So when a decision for reopening was made, regional variation and flexibility should also be considered, and we have to respond to the needs of the family, the students, and also the school staff. The expertise of public health, the infectious diseases, the education, and the community's values and priorities should be looked into. And it also requires a protocol for monitoring data on the virus to track community spread. So I think now the schools are closed, it's going to open. So regarding a research gap, research area, I think how the regarding the transmissibility in the community will be very important. So there are definite steps which have gone into the phases of reopening. The decision to reopening was made, and this is based on the Western reference from UK. They have thought that districts should bear the relative health risks. So in our place also, now we have got this natural calamities. So how far that school reopening in some areas, not districts, but some areas. So that will be a very important point regarding us. So prioritize reopening with an emphasis on providing full-time in-person instruction in the primary grades. As we all know, primary grades may be a little more safe. But students with special needs, in West, they have actually suggested that they can go for an physical mode. But in our place, how far this children with special needs would be best served may be a little difficult. Second step was like precautions for reopening. Provision of the safety, that is all the masks, sanitizers, etc., and also the effective school hygiene. And also all areas, wherever in the corridor, like in hospitals we keep, there should be foot operated hand sanitizers. In areas where small children are there, it cannot be just kept like that. So children can inadvertently use it also. So these are all probably easy for a West, but these are things which will be difficult for us. Regarding the cooperation between the school health and the public health officials, prior to opening, the district or the local public health officials should verify how far they are safe with the state and the national protocol. Definitely a protocol for monitoring the data on the community spread, and also if there is a problem, it should be immediately looked into, and decisions regarding changes also should be made. And training to the staff, community, and students regarding further COVID-related prevention and health promotion after school opening should also be done. Then access to public health expertise, access to an ongoing support with the public health officials to monitor and maintain the health of the students and the staff must be there. Regarding decision-making coalitions, cross-sector task force, we all know the different intersectoral cooperation should be there. And they should look into the opening of schools, the finance, the staffing, the facilities, and ongoing decisions should be revised also as and when it comes. And there should be a definite plan for communication with the parents, the community, the LSG, etc. And definitely equity has been a problem with COVID. Shija had said regarding Congo, less than 2% of at least one dose they have received. So equity, even in our place, we should across schools and also within schools. So there should be a definite plan to address the disparities, especially regarding resources, academic and also preventive. And then assess the financial burdens. Probably these may not be much problem here. So what are the school-based non-pharmacological interventions, the seating arrangement, how many children can be allowed to school at it. So all these things, definite guidelines have come out. Basically, it is the SMS only, prioritize mask wearing, healthy hand hygiene solutions, physical distancing, limiting large gatherings, cleaning, ventilation, air filtration, and creating small cohorts of students. These are some of the strategies which, our school reopening guidelines have also followed all these principles. So this is evidence from rapid systematic reviews which has been done. And I'm not going to detail, this will be available in the with the KUHAS only. So how they have looked into the physical distance, mask for the staff, mask at source. So whatever is that, staff should definitely be masked. So that is very important. So these are the, I'm not going to detail. So these are the reports which are given us regarding evidence regarding how it should be done. And I think regarding urgent research, children and transmission of COVID after school reopening is definitely an area which we should look into. How this reopening of schools have contributed, especially across different age groups, and the role of airborne transmission in COVID-19, how this adherence to these SMS strategies and the effectiveness, and regarding surface sanitization and transmission to fomites. All these things may be undertaken. There are a lot of gray areas. The role of children in household transmission after school reopening, and the criteria for return to school of children who have tested positive, then flexibility between attendance at school and remote education for high-risk children, then internet connectivity for all children. For the teachers also, if it's going to be in a hybrid mode, it is going to be more difficult. They have to take a then parental support in teaching learning in virtual platforms. So Government of India had put down guidelines for two areas, that is health and safety and teaching and assignment. Very important is that checklists are there for parents, students, children to follow. And special importance is given to mental health, as I said, and there should be a written consent on part of the parents. So I think some parents are already speaking. If when you ask for a consent, definitely parents will worry that there is going to be some problem like that. And some people are even thinking of keeping their children at homes, even without sending to school, some areas. So in the campus, there should be no enforcement of attendance. Staggered timetables must be used, 6 feet distance, hostels, how they are managing. For all these things, definite guidelines are there. And this is there in the Margarega Education Department website. So the Kerala state guidelines are in framework with the Government of India directives. There is a staggered reopening of schools in a phased manner. Then there is definite provision of masks, etc. has been made. They'll be opened in a hybrid mode. And online classes will still continue for those who are unable to reach the school directly. Initially, small number, 10 per class will be only allowed, and all staff definitely to get 2 doses. And a school level helpline will be there. All teachers are definitely required, and that means academics have to now be built up. And schools should keep medical examination register and prepare sick rooms for children in case of symptoms. So they have to inform the parents, and then they have to communicate regarding the further management of the children who have tested positive. But there are a lot of challenges. In West, liberal use of this testing, that is, it can be antigen or RT-PCR testing, it's not very practical as in West for our children. Parental consent and the shared decision making may be issues in some areas. Then transport, it's said that it's better you transport your children singly to the school. That's all not possible. We have seen how our system works. So how far is transport possible in places like India? Because in West and all, mostly the children go to regional schools, especially younger age children. And then regarding the mitigation practices like crowding, keeping in small groups, safe distancing, practicing hand hygiene, COVID appropriate behavior, sanitizing the premises, then academics like instructions, learning methods, assignments, they all have to undergo a great change in this period. And then assessing the stress of children and also helping them out. And then definitely vaccines, if they are going to come, how it's going to be being done. So these are some of the references which I've done. And myself and Dr. Sindhu, we thank Honorable Vice Chancellor Kuhas and mentor Dr. Rajmohan sir. And thank you all.
Thank you, Geeta. Any Sindhu, any other comments? Sindhu, please ask Sindhu to join. Any comments, Sindhu?
Everything. I think there is not much to add to me. I think there's
both of you have together. Okay, thanks. Now we will have some quick comments about this session by Dr. Elizabeth Madam is there, and also by Dr. Indu PF, a professor of community medicine who has been very much involved in policy decisions. Then we will go to other comments and discussion. And Madam, Jamila Madam, kindly ask Dr. Dr. Elizabeth and Dr. Indu PS to give quick comments.
Yeah. Dr. Elizabeth, I think she's here. Dr. Elizabeth, please.
Thank you very much for this opportunity. I was listening to this topics very well presented, and very good messages we are getting. I think as rightly pointed out, even we cannot plan at state level. We'll have to plan region wise because of the climate changes and the situations in Kerala. The schools are under the local self-government. So I think there should be some brainstorming and some micro planning should be done. And that should be applicable to the local private institutions also. Then safe transport. I am really concerned about how they are going to transport. If 10 children are there, are they going to send the vehicles or it will be the parents? Now the parents are work from home, so they are too much overworked. I think they may not have the right to safely take the children home. And it is going to be shift or half day schools also, no? So different timings the children have to be picked up. I think a lot of planning is needed. And most of the queries have been addressed. Some more brainstorming is needed as the slide was saying. Thank you very much.
Thank you very much. Dr. Sindhu.
Madam?
Yes. Have
Madam,
you got any comments?
No, madam. Next.
Okay, thank you. Thank you. So we had a very wonderful session on the school opening and safe schooling. I think as Dr. Elizabeth mentioned, we have to have a micro planning because 3 departments have to work hand in hand: health department, education department, and local self-government. And lot of awareness has to go to the teachers because they have a huge responsibility. Not only they have to not only concentrate on the academics, but also on the safety and health of children also. So there should be a very coordinated effort by the teachers for the prevention and control of the COVID. And health department should be ready to help the schools, each and every school. That is a very difficult task for the health department because in each panchayat they'll be having 4 or 5 schools, and very difficult to look after all the children every day. But it is a huge challenge before us. And anyway, we have to live with COVID and we have to adjust ourselves to fit into the new situation. And I think we have to learn how to reopen our school with all the even though all guidelines are there, many difficulties and many gaps will be felt in each and every school. And we have to deal with that. And I think health department is ready to take up the challenge.
Jamila Madam, one comment about the government policy was to give at least 1 dose of vaccine to the teachers. Now, from Dr. Gita's presentation, it is 2 doses to be given. What is the latest policy? Is it at least 1 dose? Then that is
at least 1 dose. At least 1 dose.
That's not enough, because the 1 dose give protection to the new Delta variant 30% only, and
Yes.
these teachers and the other workers are at highest risk. So that's a wrong decision. That should be conveyed to the administrators. Because and one more thing, if at all we are giving the vaccine to the left out people, the highest susceptibles and the teachers, you can utilize the Covaxin so that we can complete the dosages at the earliest.
Yes, yes. This is a very valid suggestion. Actually, I think it was 1 month or 2 months back, the decision was taken at least 1 dose, because that time there was a problem with the availability of vaccine. Now we have enough vaccine and enough human resources to give vaccination also. So I think we should prioritize the vaccination schedule for teachers and other staff in the school, not only teachers, ministerial staff and other attenders or sweepers, whoever it is, part-time sweepers, everybody, whoever is working in the school has to take 2 vaccinations.
Thank you, madam. Indu is there. Indu PS. Can you make some quick comments?
Sir, from the public health point, I think IFP is one, pediatricians is one group which, I mean, so close to public health. I mean, every aspect of health system.
I think it's not there.
Not audible.
Not audible.
ഇപ്പൊ കേൾക്കാം, കുറച്ച് ഒന്ന് പറഞ്ഞോളൂ. എന്തോ
കേൾക്കാമോ മാഡം?
യെസ്
മാഡം, ഇത് നമുക്ക് ഡേറ്റ വേണമെന്നുള്ളത് ശരിയാണ് മാഡം. കാരണം പീഡിയാട്രീഷ്യൻസ്, എനിക്ക് എപ്പോഴും പറയാനുള്ളത് പീഡിയാട്രീഷ്യനും പീഡിയാട്രിക്സും IAP ആണ് എപ്പോഴും പബ്ലിക് ഹെൽത്തിനോട് ഏറ്റവും അടുത്ത് നിൽക്കുന്നത്. അപ്പൊ അതുകൊണ്ട് നമ്മളിപ്പോ സീറോ സർവേയുടെ വെച്ച് നോക്കുകയാണെങ്കിൽ 40% ആണ് കുട്ടികൾ അതിലുള്ള സീറോ പോസിറ്റിവിറ്റി, 60% സീറോ നെഗറ്റിവിറ്റി അവരാണ്. അഡൾട്ട്സിനെ സംബന്ധിച്ചിടത്തോളം 86% ആണ് നമുക്ക്. നമ്മുടെ അൺവാക്സിനേറ്റഡിലെ സീറോ പോസിറ്റിവിറ്റി 70%. നമുക്ക് ഇപ്പൊ ഇന്നത്തെ അല്ലെങ്കിൽ ഈ അടുത്ത സമയത്ത് ICU അഡ്മിഷനോ മോർട്ടാലിറ്റിയോ നോക്കുകയാണെങ്കിൽ മോസ്റ്റ്ലി സിംഗിൾ ഡോസ് അല്ലെങ്കിൽ അൺവാക്സിനേറ്റഡ് ആണ് നമ്മുടെ മോർട്ടാലിറ്റി മുഴുവൻ. അപ്പൊ അതുകൊണ്ട് ഇതില് വാക്സിനേഷൻ എമോങ് ചിൽഡ്രൻ എന്ന് പറഞ്ഞാൽ കമ്മ്യൂണിറ്റി, നമ്മുടെ കേരളത്തിന്റെ പോപ്പുലേഷനിൽ കുട്ടികളുടെ പ്രൊപ്പോർഷൻ, കുട്ടികൾ ഇനി കാരണം അവരാണ് ഈ കൂടുതൽ നാൾ ഇവിടെ ഉള്ളത്. അപ്പൊ അതുകൊണ്ടൊക്കെ കുട്ടികളുടെ ഇമ്മ്യൂണൈസേഷൻ തീർച്ചയായിട്ടും കൺസിഡർ ചെയ്യേണ്ടി വരും. പക്ഷേ അറ്റ് ദി എൻഡ് ഓഫ് നമുക്ക് ഡേറ്റ ഡെഫിനറ്റ്ലി നീഡഡ് ആണ് ഓൺ സേഫ്റ്റി ആൻഡ് എഫിക്കസി. ഡേറ്റ വേണമെന്നുള്ളതിന് സംശയമൊന്നുമില്ല. ഇതിനിടയ്ക്ക് നമ്മുടെ ഈ ചാറ്റ് ബോക്സിൽ വന്ന 1-2 കാര്യങ്ങളിൽ 2% മോർട്ടാലിറ്റി അത് വാക്സിനേറ്റഡിൽ എങ്ങനെ 2%? അത് വാക്സിനേറ്റഡ് 2% വരുന്നതല്ല. ആകെ CDCയുടെ കോവിഡ് മോർട്ടാലിറ്റി, ആകെ കോവിഡ് ഡെത്ത്സ് എടുത്തപ്പം അതില് 2% ഉള്ളൂ എന്നുള്ളതാണ്. അതില് വാക്സിനേറ്റഡ് ആളുകൾ എന്നുള്ളതാണ്. നമ്മുടെ ഡേറ്റയും ഏതാണ്ട് അതുപോലെയാണ്. നമ്മൾ കോമോബിഡിറ്റി കൂടെ എടുത്ത് നോക്കുകയാണെങ്കിൽ വളരെ കുറവാണ്. കോമോബിഡിറ്റി ഉള്ള അല്ലെങ്കിൽ കുറച്ചുകൂടി പ്രൊപ്പോർഷൻസ് വരും. Still it is single dose. Now earlier it was mostly unvaccinated, now single dose. നമ്മുടെ മോർട്ടാലിറ്റി ഓഫ് കോഴ്സ് അഡൾട്ട്സ് ആൻഡ് എൽഡർലി അതാണ്. അപ്പൊ അതുകൊണ്ട് ചൈൽഡ് വാക്സിനേഷനും ഇപ്പൊ നമ്മളുടെ ഒരു സീറോ സർവേയുടെ സീറോ പോസിറ്റിവിറ്റി കൂടെ നോക്കുകയാണെങ്കിൽ നമ്മുടെ അൺവാക്സിനേറ്റഡ് അഡൾട്ട്സിൽ 70% സീറോ പോസിറ്റീവ് ആണ്. രണ്ടും കൂടെ ചേർത്തിട്ടാണെങ്കിൽ 86%. അതേസമയം കുട്ടികൾ 40 ഉള്ളൂ. അത് ഷിഫ്റ്റ് വൈസ് കമ്പാരിസണിന് നമുക്ക് ഡേറ്റ ഇല്ല. പക്ഷേ പബ്ലിക് ഹെൽത്ത് ആൻഡ് സോഷ്യൽ മെഷേഴ്സ് അതാണ് ഇതിന്റെ ഒരു ഹൈലൈറ്റ്. എന്തായാലും നമ്മൾ ഇമ്മീഡിയറ്റ്ലി സ്കൂൾ തുറക്കുന്നതിന് മുമ്പ് വാക്സിൻ എത്തില്ല എന്നുള്ളത് വരുന്നത് കൊണ്ട്, അല്ലെങ്കിൽ തന്നെയും പബ്ലിക് ഹെൽത്ത് ആൻഡ് സോഷ്യൽ മെഷേഴ്സ് ഇൻക്ലൂഡിംഗ് മാസ് സോഷ്യൽ ഡിസ്റ്റൻസിങ്, ഡീസെൻട്രലൈസേഷൻ ഓഫ് ആക്ഷൻ, ഗ്രാനുലാരിറ്റി ഓഫ് ഡേറ്റ പഞ്ചായത്ത് അല്ലെങ്കിൽ സ്കൂൾ തലത്തിലുള്ള ഡേറ്റ അനലൈസ് ചെയ്യാനുള്ള സംവിധാനം എന്താണ്, അതാണ് ഇപ്പോൾ ചോദിച്ചത്. അപ്പൊ അത്തരത്തില് നമ്മൾ അഡൾട്ട്സിനെ അല്ലെങ്കിൽ കമ്മ്യൂണിറ്റിയിൽ എങ്ങനെയാണോ ഇതിനെ മാനേജ് ചെയ്തത് അതിന്റെ ഒരു ഡേറ്റ ഫോളോ അപ്പിലും കുറച്ചുകൂടി വ്യത്യസ്തമാണ് നമ്മൾ ഈ സ്കൂൾ തുറക്കുന്നതിലുള്ള സാഹചര്യം. എനിക്ക് ഫൈനലി ഒരു കാര്യം കൂടെ പറയാനുള്ളത്, വാക്സിൻ ഏറ്റവും കൂടുതൽ നമ്മൾ കുട്ടികളിലും പീഡിയാട്രിഷ്യൻസും പീഡിയാട്രിക് പ്രാക്ടീസിലുമാണ് വരുന്നത്. അപ്പൊ നമ്മൾ ഈ ഒരു കോണ്ടെക്സ്റ്റില് ഒരുപാട് വിവാദങ്ങൾ കുട്ടികളുടെ വാക്സിനെ സംബന്ധിച്ച് വരുന്നതില് I think definitely data is required. There's no doubt about it. We are all talking science. But let me also not confuse the public with statements like, is vaccine indicated for children? Recently, we were going through the titles in newspapers. Something ഇതുവരെ കുട്ടികളെ എല്ലാം വാക്സിൻ കൊണ്ട് സംരക്ഷിക്കുമെന്ന് നമ്മൾ പറഞ്ഞു. ഇപ്പൊ എന്തോ ഒരു കുട്ടികളുടെ വാക്സിൻ ഒരു പ്രശ്നമാണ് എന്നുള്ളത് സയൻസ് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുന്നതും പൊതുജനം പെർസീവ് ചെയ്യുന്ന ഒരു പോയിന്റ് കൂടി ഇത്തരത്തില് ഈ വലിയ വിവാദങ്ങൾ വരാതിരിക്കുന്ന ഒരു ഒരു സൂക്ഷ്മത കൂടി നമ്മളുടെ ഇറ്റ്സ് ഓൾ കമ്മ്യൂണിക്കേഷൻ. വി ആർ ഓൾ ടോക്കിംഗ് അബൌട്ട് ലിറ്ററസി, എൻഗേജിങ് ദി കമ്മ്യൂണിറ്റി ആൻഡ് കമ്മ്യൂണിക്കേറ്റിംഗ് സയൻസ്. അപ്പൊ അതിൻ്റെ അകത്തുള്ള ഒരു സൂക്ഷ്മത കൂടി ഈ ഒരു സമയത്ത് വേണമെന്ന് ചില വാർത്താ തലക്കെട്ടുകൾ കാണുമ്പോൾ നമുക്ക് തോന്നുന്നു. That's purely from a public health point of view, because it is the society's risk versus the society's benefit. Children's risk versus children's benefit.
Okay, thank you.
It's a wonderful program. Jamila ma'am, everyone, wonderful program. Jyoti, Dr. Sija, Dr. Geeta, Dr. Priya, everyone. Thank you.
Thank you, Dr. Indu. നമുക്ക് നല്ലൊരു 3 സെഷൻസ്.
Madam, Dr. Mohandas from Calicut. Madam, Dr. Mohandas from Calicut was making a comments in the chat box. Mohandas, can you explain what your points? Mohandas?
So what I was mentioning is, even now, among the above 18 age groups, our those who have received 2 doses are only 50%. And we have limited supply of vaccines also, and safety in children is not established. So our concentration should be to vaccinate all the adults 2 doses rather than vaccinating children right now.
Yes, of course. അതാണ് ഞാൻ നേരത്തെ പറഞ്ഞത്. Because 50% ഇല്ല. Second dose 47% ഉള്ളൂ 2 doses എടുത്തത്. So നമുക്കൊരു 11.9 lakh ആൾക്കാർ സെക്കൻഡ് ഡോസ് എടുക്കാൻ ഓവർ ഡ്യൂ ആയിട്ടുണ്ട്. So 1.26 lakhs ഇനി വാക്സിനേഷൻ എടുക്കാനുണ്ട്. Of course, our priority will be that. But the state cannot take a decision for starting vaccination in children unless Government of India gives us direction. Adu tannitilla. So we have to wait for that. Once Government of India gives direction to the state, we have to start also.
Okay. I have a question. I don't know. The point is, we are discussing about the opening up of the schools. That means children up to 17 years. We are going to open up the colleges also. In fact, the only colleges which are
sir, please air out, sir. Please air out your question.
The only colleges which are open as on today is the colleges under Health University only, and most of our students have received vaccine, and we did not have any issue. Now the arts and science colleges are going to be opened. The engineering colleges have to be opened, and they were supposed to be opened on 17th or 18th. Now they will be opened on 25th. And how many of them have received vaccine? Because earlier we were giving vaccine only to people above 40. Then subsequently it was made it between 18 and 40. So this also is a big issue. Somehow we are not discussing that issue, problem, because large number of young persons who may not have received vaccine at all, or they might have received one vaccine. The people who are going for the arts and science colleges, engineering colleges, polytechnics, should we address that issue also?
Of course, we have to address that issue also, because opening colleges means they have to take vaccine. Actually, age-wise vaccination status is available in the Covet app. I don't have it right now. I think it is data is available.
Madam, just a few comments about after hearing all the presentations. After hearing the first and second presentation, Janaki pointed out how the national programs are affected. We are all aware how non-communicable diseases and all the other services are affected. And in the next presentation, in Priya's presentation, she said the cases admitted, majority could have been managed at a lower level. Even now, we are continuing. The management of many of the cases not deserve to be managed in the medical colleges, and that's affecting the teaching also. So we should be learning lesson from whatever you have learned, and hereafter at least for the rest of the time itself, there should be a shift of the management to the middle level institutions. That is one. Second point is about the management in the SIT hospital, well managed, 1,000 and above. Calicut 980 cases, Trichur and all other medical colleges somewhere around 400 cases. We have enough data, but the treatment protocol we followed were not uniform. Especially in Trivandrum SIT, they were using, Shrija was giving aspirin for all, but in Thrissur we are not giving, Calicut also. So there were difference in the treatment protocol. So we should be following all the cases for maybe another year and say whether there's a difference. Because the Western countries' recommendation, hydrocortisone they are recommending, the anakinra they are recommending, but we could manage the SAT protocol. The result with the steroid was much better. So our the data should be, we should be making our own protocols, and the comparison of this follow-up should be there about this thing. And the last part, I was very much interested about the Priya's last case of the antibiotic, the monoclonal antibody cocktail given to the 16-year-old kid. I was thinking, why not in the coming years as a research protocol? We have enough experience with the monoclonal antibody cocktail in the adults now. Only the problem is the cost. It's safe, very effective among the adults. So in a deserving pediatric population, highest risk patient group, especially in a little older category, about 12 is only recommended. So we should be using it more in the coming days when more and more of problems in the MIS and all in the adolescent group are happening. And maybe with that, a highest risk group below 12 also we can use the monoclonal antibody cocktails, and so that we can have our own data.
Yes, I fully agree with you. That's what I mentioned earlier, that we have to have a registry, and there should be a uniform protocol, and KUHS can take the lead for this.
Thank you, madam. Thank you. I think now it is almost 9, and if there are not much questions, we can wind up. Otherwise, we can continue for a little time. I don't think any much other glaring. We have covered most of the things. So I request our Honorable Vice Chancellor to make the concluding comments.
This definitely was a wonderful session. In fact, in the beginning, I asked a lot of questions, and some are answered, and some questions still remain. And these questions, definitely, we will have to find out answers and through research only. And if our faculty are ready to join, the university is always willing to support whatever way. And definitely, we can even think about funding also. We can help our faculty so that we can find answers for these problems. And like Professor Dr. Jamila has said about the registry, definitely we are ready for that. But only thing is how it can be worked out, we'll have to think about it. And I hope there will be a lot of support from the planning board, from Dr. Jamila, and definitely we will go ahead with this program. And I thank once again all the speakers. You have done your job very good, wonderful way. You have done excellent. Thank you. Thank you so much.
Thank you.
Thank you, sir. Thank you, sir. And all the presentations of today will be available on the site, maybe after 1 or 2 days, maybe possibly on Monday. And we will be coming out with a good document also, which will be also uploaded in the site. Thank you all once again. Thank you, Jamila madam. And thank you all respected seniors and also my colleagues. Thanks.